the liberal usage of FFP and other blood products can lead to worsening survival and worsening portal hypertension because, again, there is this venous group or the portal system that is now decompressing because of the variceal hemorrhage. It has a certain capacitance, and it'll be continued decompressing actually. And now you're just filling it up with more and more and more and more from the colloid that you're giving them. So trying to stay away from over resuscitation is actually very important in the cirrhotic population.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Cyrus Askey, here with my co-host, Dr. Nick Mark.
Hey, man. How's it going? Getting ready for our co-family vacation to Miami. Kids are excited. I'm excited. Yeah, it's going to be great.
It's going to be great. The weather is going to be great, I think. In anticipation, I went ahead and got most of season one.
You got a really skimpy bikini, didn't you?
I did. Well, okay. First of all, didn't need to get that. Already had it.
Gotcha.
Second of all, got caught up on at least season 1 of Andor.
All right.
So
we'll have something to talk about.
We'll have something to talk about, because otherwise we'd have literally nothing to talk about.
Yeah, just nothing to say.
But anyway, so yeah, that's kind of the news from my neck of the woods. Anything else exciting going on with you, Nick?
Last day of school today for the kiddos. So my summer of Ubering them to camps, basically being their Uber driver is now beginning. Very
Awesome.
Exciting. Yeah,
Cool.
I don't know. It's summer vacations were way more exciting when you're a kid, I think.
Yeah, I think you're probably right on that note. Cool. All right. Well,
what are we chatting about today, man?
Yeah, I suppose we should probably get to it. So for those of you guys that listened to us a couple weeks ago, you would have had the pleasure of meeting Dr. David Dulaney, gastroenterologist in San Antonio, who's also the program director for one of the GI fellowships in town. In addition to that, he's an assistant professor with the Uniformed Services University and a joint assistant professor at UT Health Science Center in San Antonio with numerous academic accolades. He's taught both domestically and internationally. And guess what? He is back with us today. He spoke with us previously about non-variceal GI bleeds, and we thought it would be fitting to continue exploring the GI system, as it were, by delving into cirrhosis and talking about variceal GI bleeds.
So we're wandering above the ligament of Treitz today. This is going to be great. Yeah, exciting stuff. Lots of clinically relevant pearls. Let's just get to it.
Let's do it.
Hey, David, welcome back to the show. Great to have you again, man.
Hey, thanks so much for having me, guys.
What's new in your neck of the woods?
Oh, well, I guess hearing your guys' conversations, no kids in school or into the school year, but we're at the end of the academic year now, so this is the faux summer vacation for a week before, as our older fellows leave and our new ones come in, so that's that time here.
So you're looking forward to being really hands-on again?
Yes.
You go from maximally hands-off to maximally hands-on.
Pretty much, yeah. So, I mean, we're kinder and gentler. We start people off a little bit easier in our curriculum, but, with like not being on consults day one, because I couldn't imagine the nightmare of, hi, welcome to July 1st, here's your pager. But,
goes off as you're handing it
exactly.
to them.
Oh, by the way, there's someone, someone like
there's
maybe
3 waiting for you.
Recently, yeah. But clinically, yeah, I think it's funny. It's like really fortuitous that we're talking about this now, because like just a week or two ago, I put in a Blakemore tube in someone, and like I hadn't done that in a little while now. So it was
I put in one last week too, actually.
Yeah, good refresher of physiology.
Did what I could to prepare for this episode. Yeah, that's
perfect. Yeah. Cyrus, did you put one in?
I solidified my life insurance policy.
Okay, good.
That's good.
Maybe something also that's good to do if you have child PUC cirrhosis, although that would be quite expensive. So
you're right. Yeah, readily attainable, I'm sure.
Something tells me, the premiums will be quite high.
You might need to find a physician to do your physical who can't see you.
Right.
Like do it over Zoom or something.
Yeah, with like a fax modem connection. So yeah, I think, okay. Cat's out of the bag. We've gotten caught up a little bit. And so, I think we can probably go ahead and really get started here. And what I was thinking is kind of a lot of times we'll lay out some background information, sort of do some like almost didactics before we get into the case. But I figured, why don't we just start with the case right off the bat and use that as the means by which we unpack the content that we're gonna get to today. So, without further ado, we'll say it is the middle of a stormy night in a busy tertiary ICU, and you get a page for a gentleman by the name of Mr. Manny Ramirez.
Oh no, from a
A
Red Sox fan himself too.
That's
Jeez, I can't
right.
believe you did that.
I know, I had to. He's a 56-year-old man. He's got child Q class C cirrhosis. His last meld calculated was 24. This is related to history of alcohol use disorder resulting in said cirrhosis. And so he's actually coming in from the emergency department after profuse hematemesis that was first noted in triage.
I'll fill in some more details of the case here. So his blood pressure is 86/50. His heart rate is 122, respiratory rate 28, satting 93% on 4 liters. He's somnolent but arousable. There's a flapping tremor present bilaterally. His GCS is 10. The nursing staff has placed 2 18-gauge peripherals. There's a type and cross pending. His initial hemoglobin is 7.4. It was 10.8 just 4 hours ago. Platelets are 46, INR is 2.1, fibrinogen 95, lactate 5.7. I feel like I should give you a batting average, home runs, and a HCG as well.
Yes, that's right. And
That's a little deep baseball jab right there, you know.
Jeez, yeah, that's come on, man, that's hurtful. I love baseball. Okay, and sometimes that HCG matters. If who could say, what is it, choriocarcinoma?
Yes,
You got to
yeah,
be
you
on the
could.
lookout, right?
Yeah,
So okay,
that's why
so
I drink so much.
getting back to Manny here. So boots on the ground, do a bedside ultrasound. You see small underfilled IVC, flat hepatic veins, underfilled RV, nodular liver with splenomegaly. Go ahead and start octreotide, and you've got some ceftriaxone that is
And
hanging
we'll
as
talk about
well.
why in just a second too.
We will. We're so good. We just knew to do that, but we're going to talk about the why behind the what here in a little bit. GI. So you, David, with concern for a variceal bleed, you are at least 45 60 minutes out in the best case scenario. And kind of all parties on the call here, all parties present to the patient, feel like some resuscitation is going to be needed first and foremost before any sort of endoscopy. So going back to boots on the ground, thoughts are being collected, and while you're sort of coming up with your game plan, you hear some gurgling from the patient's room. He retches again. The intern that's kind of part of the team is like, oh man, should we intubate him now? Do we need to be giving him blood kind of now, giving him blood fast? How do we do it? What about an FFP for that INR? And then you've got like interventional radiologist gets involved. They're wondering if this is like an early tips candidate. So there's just so many things to unpack here. Yeah, it's just a very busy situation.
All right, so David, answer all of those questions. Go.
Right. Yeah. Exactly. Ready. Go. No, I think that's like kind of we'll have a little bit more to say before we really delve into the nitty gritty of it. But that's for those who are listening, especially if you're new to medical training, as a medical student or an intern, this is very similar to how things go. They come in and it's very fast. It's very scary. It's very dramatic seeing a lot of blood pouring out from someone's mouth. But we'll talk today about a lot of things that we need to kind of go over. And I think you guys did a great job of summing up the case. And there's a lot of things we'll talk about later about like when you consult the gastroenterologist, things that I like to know or like to hear about, from that, so I can kind of build my differential, as it were. Here it's kind of obvious of what's going on, but there's still some things that we need to kind of look at and be considering as well. So
Perfect.
great
Perfect.
case thus far. Let's see where it
Yeah,
goes.
no, absolutely.
Why don't we back up and maybe give us some background on like how serious is this? Like, is this an emergency? Why should we be so concerned about this?
Oh yeah, for sure. So obviously several points about Mr. Ramirez's case. Of course, we're saying that his prior MEL is 24. So obviously just at baseline, he's a rather sick gentleman from his in terms of his liver function. That may also portend synthetic function, renal dysfunction, things of that nature as well can be kind of encompassed into that meld as well. And then looking through him here, of course, obviously hypotense, he's tachycardic, his somnolence could portend that is has obviously some hepatic encephalopathy, maybe at baseline, maybe this is a new thing for him. But where he's at right now, especially the amount of blood he's losing is very concerning that we, as I mentioned, may need to intubate him or things like that. When I'm getting these calls, or when I have a fellow staff, things that we're always talking about, the hemoglobin drops and stuff like that. But for him as well, anyone can have any issue, something like an ulcer or something like that, a normal cause of bleeding as well. But when I hear the platelets of 46, that's where, based on Bovino criteria, I'm really thinking, okay, this gentleman has, even though we know he has cirrhosis and likely already had some clinically significant portal hypertension, although we didn't talk about other sequelae of that in the question stem, as it were. Once I hear platelets of 46,000, I'm thinking, okay, this guy has portal hypertension. I'm really thinking this is a bleed, everything like that. So, that's just what I'm thinking. I say, okay, this dude's really sick at baseline. Taking it forward there, thinking, okay, what's the risk of this? We can talk about, the other types of GI bleeding that physiologically could act differently. But, variceal hemorrhages, even with a lot of the advancements, all comers, all places, generally in sort of large multi-center or like tertiary center studies, mortality is around 10 to 15%. And that's like short-term mortality. So it's in like 6 weeks of presentation there. So very serious emergencies. But these ones, the interesting thing about them is because of all their physiology and other interventions that can be performed, they require a lot of multidisciplinary care to manage. So, I don't know the direct numbers of it per se, but I feel like if you're in a place where you're unable to provide that kind of multidisciplinary care, I anticipate that the mortality rates would be higher from someone with a true variceal hemorrhage.
And I think that just the MELD score of 24 is going to be around, that 15 to 20% mortality anyway.
Mm-hmm.
And that's even without the GI
that's
bleed,
just
right?
Living your life at 24. You have a very high, that's in some regions, that's getting close to sort of the transplantable numbers, depending on where you are, depending what the availability is, and depending on many other things, of course. But that's a pretty high. You generally, Mr. Ramirez should be followed at a transplant center at that kind of meld with it. So, yeah, no, I totally agree, Nick.
So, David, you already kind of alluded to this earlier in the discussion, but really the culprit here is portal hypertension in the setting of this patient's cirrhosis. And so I think we don't want to bite off more than we can chew, but I feel that we would be remiss not to sort of discuss the pathology and the pathophysiology associated with cirrhosis as we kind of lean into variceal bleeds. So maybe we can
Please walk us through the molecular mechanisms in exquisite depth.
In
Gladly.
exquisite depth.
This will be the first 6-hour episode of critical care time.
That'll just be part one.
Yeah. For your interns who can't sleep very well, maybe you're nervous. This will be a great chance for you to catch some Z's while I'm talking about all this.
Gosh.
And here we go.
You guys, insanity ensues. No. So maybe we can just talk about common causes of cirrhosis. What is cirrhosis? Things like compensated versus decompensated. Just some of those basic foundational concepts that we need to know about.
Right. So cirrhosis itself, I guess we'll take a step back there. So that's where there's some insult, chronic insult to the liver causing injury, and then there's the sort of disordered healing of such. So there's a couple, when it's basically on the pathological side, when you're looking at slides, it's sort of the fibrosis between the lobes of the liver there, causing some kind of dysfunction of it. So when we're talking about portal hypertension, the original sort of back within the liver cause of it is increased vascular resistance through the liver through activated stem cells, leading to increased sort of proliferation, collagen synthesis within the lobes between the architecture of the liver, and then increased hepatic vascular tone, so more vasoconstriction, endothelial dysfunction, microthrombi as well. Basically leads to the whole portal vein, from where it enters the liver, backing up an increased portal vascular flow. The things that lead to that, of course, or it leads from it, is spleen vasodilation and decreased sensitivity to vasoconstriction. And then eventually that leads to these portosystemic collaterals. So the elevated portal pressure, local anatomic factors. So remember the hemiasgus system that can basically where your varices come.
I'm sure all of our listeners fondly remember the hemiasgus system.
Yeah, of course, yes. And the other angiogenesis leads to basically gastroesophageal varices, which is what we're kind of talking about today. Now, other sequelae of it, you'll hear about hepatic encephalopathy, maybe you guys will discuss, obviously, when we talk about circulation and hyperdynamic circulation, the issues um, with that. And then, of course, ascites and hepatorenal syndrome are things that we think about as well. So, to take a step back, stuff that, let's think about to when you called about Mr. Ramirez, of course, I already mentioned the platelets. So that's portends clinically significant portal hypertension. But what other signs of it is anything, or what we would call something that lead to decompensated cirrhosis, is these overt sequelae of clinically significant portal hypertension, something like ascites. Now we have, because of the splanchnic vasodilation, overall the rest of your body is seeing a decrease in effective arterial blood flow, activating the RAS system and the sympathetic nervous system and things like that. The renal arteries constrict, you get more sodium retention, and then that just starts this never-ending cycle of ascites being collected within the abdominal cavity. And I already talked about the collaterals and the varices and things like that. And then the hepatic encephalopathy, again, you get these portosystemic shunts of some kinds of varices, or some of them kappa medusa, things of that nature, which then take, basically, as we'll call them, just sort of metabolic toxins from the gut, translocate them where they're not sort of filtered per se and metabolized in the liver through the systemic vasculature. So then those that can affect the brain, cross the blood-brain barrier, will do so, and leads to the hepatic encephalopathy from the portal hypertension. The question is sort of, okay, yes, we can all see those clinically significant things, and clinically significant portal hypertension sequelae, and that's generally where I'd say is sort of the decompensated side. For those who really want to get scientific about it, that's for like the protosystemic gradients around 10 millimeters of mercury. Those more severe ones, you'll get 12, 15 or higher for that gradient. But the long and short of it is, when I'm hearing about a cirrhotic patient, those are the things that I mentioned of decompensation are things that I really want to know about, because have they had varices before? Have they ever been banded before? Because that matters, and maybe how recently they've been banded, because that may honestly change what we'll do, whether it's endoscopy or not. And we can talk about that kind of as we get more towards the treatment of him too, in terms of ascites and whether he's had spontaneous bacterial peritonitis before, and then hepatic encephalopathy, because that may drive where we think we're going with, mentioned GCS of 10. He's somnolent, but arousal would, maybe this may, if we know he has HE at baseline, maybe it'll push us more towards like being a bit more aggressive with intubation to start. Those are the kind of things that we sort of look for them. So hopefully that answers the question fully and isn't too boring. We're under 6 hours, so I think we're good.
Yeah, we're doing pretty well timing wise. Yeah, I think it's
good.
a great summary of like injury, impaired healing, fibrosis, which causes increased pressure. You also have impaired synthetic function, impaired metabolic function, all these nasty brain toxins building up, causing encephalopathy. One other point maybe to emphasize too is that you accumulate vasodilators like nitric oxide.
Yes,
so
definitely.
Something we often talk about on this podcast is like the sort of strategy of using vasodilator scavengers, which seems to work well in patients who have a lot of them, like these patients.
So, yeah, I think the great discussion, and that in and of itself was a Herculean task. So that's hats off to you. Before kind of advancing the case, I just wanted to make sure, David, because in pre-recording you'd mentioned, rightfully so, this is an episode we plan to launch sort of early in the academic year, and so when those trainees, for example, are listening to this episode, are there any other specific elements you would want them to have kind of readily available when they're calling GI about a patient like this, other than the things you've already mentioned?
Let's see, other things than what I've already mentioned. Of course, it should come at around 7:30, 8 o'clock in the morning only.
Right.
So please delay on him. No, I think that's, mostly just about the cirrhosis to the extent that you can get it, even in more comprehensive integrated health systems, it's still hard to find all the information about some of these people because they're complicated, or sometimes, people just kind of show up at the ER with variceal hemorrhage, and you kind of just try to get the information that you can through, if there are any records, even just a good physical exam, if you sense that there's fluid in their abdomen, if they're jaundiced, if they were confused before, anything like that, sort of things just to pull from them so we can get a sense of the severity of their portal hypertension, even if you can't get endoscopy records perfectly or anything like that. So it's about trying to kind of make the best history we can, so we can be we'll still probably do an endoscopy, but at least we can be most intelligent about if that's what we're supposed to do, or maybe if it's more us as gastroenterologists getting IR on the phone at the same time or something like that.
Sure. Okay. Now that we've kind of taken that whirlwind tour through the sequelae of cirrhosis, focusing on variceal GI bleeds here. So obviously, those of us in the ICU, we love our hemodynamics, and as you sort of mentioned, these folks often will have this hyperdynamic, low SVR state that we sort of deal with and have to sort of manage. Nick, you had mentioned like nitric oxide scavengers are great. Is there, I guess, anything from a GI standpoint? Certainly, we can talk about it as intensivists, but any are there any pearls from a GI perspective related to related to resuscitation in patients like this?
Good question. I think, you mentioned, and maybe we'll talk about this more in terms of the choice and the duration of things, but octreotide, starting on, of course, that's for some of our listeners or those who listened to the first episode. Remember, that wasn't something that I mentioned as being how we would treat a, you know, peptic ulcer bleed or any of those other bleeds like that. So,
Right.
at that point, what we're really trying to do is to counteract that splenic vasodilation to basically be almost like for lack of a better term, I'm sure there's a more eloquent way to put this, sort of like a intra-abdominal vasopressor at that point. So, in terms of that's how I would approach it there. Other resuscitative things I frankly leave to the intensivists
Sure.
about their decisions on that if someone needs any other ones. But of course, octreotide is the one that you'd start first. So I would say, and it's, otherwise, let's say Mr. Ramirez is having another GI bleed. It's sort of low risk, but a very high reward intervention to make. So I'd say if you have any suspicion for it, starting that early, and it can always be peeled off after we've kind of taken this undifferentiated GI bleed and found that maybe it's not from portal hypertensive bleeding.
Yeah, I think the one detail I'd add to that is just for our listeners to remember that this tends to be a hyperdynamic shock, and that your cardiac output or your stroke volume is usually proportional to your pulse pressure. And so often these patients have a low diastolic and a wide pulse pressure. That's kind of a hint. They'll have a bounding pulse when you feel them. They'll be, kind of warm, and when you look at their hemodynamics, their map may actually be low because of that low diastolic, but they'll have like normal-ish or low normal systolic. And one question that often comes up is like, oh, their map's only in the 50s, should we get them up to 65? And I think one thing we've often talked about in this show is that, often 60 is enough. And
Right.
often, our goal is not really a number, but a perfusion state. And so often, putting, lots of pressors, lots of resuscitation to target a number is less important than sort of targeting a goal for organ perfusion and resuscitation.
Yeah, and I think I would just kind of that's exactly my approach too, kind of from the intensive care standpoint. I think the additional elements I would bring to the table, and we may actually delve a little deeper on some of these things, but I treat these folks kind of like trauma patients when I resuscitate them. So I think of them as being good candidates for permissive hypotension. And you're sort of getting to that point as well. You don't need to get their map up to a normal map. Sometimes that can be a way to buy yourself some more problems. So instead, being mindful, looking for things like perfusion, looking at your lactate trend, which of course is not going to be perfect in someone with cirrhosis, a perfect measure, and is a flawed measure in general. But using base excess, being aggressive, I think, about resuscitating the underlying problem. So this is, a hyperdynamic distributive state with hemorrhage, and the hemorrhage is something that you can act upon pretty early. And so being, I think, aggressive with the colloid resuscitation, in this case, blood resuscitation,
Mhm.
not necessarily trusting that hemoglobin value for as the be all and end all. We know that could be a lagging indicator. And then the other thing I'll add is sometimes it can take a little while to get your blood up and running. You've mentioned before, Nick, this idea of like, hey, if just because someone's in hemorrhagic shock, it doesn't mean you should withhold vasopressors. You can get a little bit of an internal bolus by using those vasopressors. And again, this is not a purely hemorrhagic state, again dealing with that low SVR. So those are
Right.
sort of like some of the principles I
Great
try to
point.
remember with these types of patients.
See, this is why I leave it to you guys. Isn't that great?
Yes, indeed.
No, it's true. Yeah, I like that you guys mentioned also being more permissive with it because, yeah, I mean, you may not know, but obviously, having seen many patients like Mr. Ramirez or those even higher melds in clinic, they come into clinic and they may live at 90 over 60s or high 80s over 50 or something like that. So shooting for a perfect map or anything like that may be really overshooting. And there are some dangers. Maybe we'll talk about this a little later of over resuscitation of these folks with any kind of blood products. So something to keep in mind.
Speaking of blood products, I mean, I guess one question that often comes up is, you know, what do we want to make the INR? Like, how much do we want to fix him? When you see coagulopathy in the setting of GI bleed, what's normal? And often it's like, if you involve, multiple different specialists, like you talk to IR, they're going to have one number in mind. If you talk to GI, perhaps a different number. Talk to, surgery, maybe a third. What are your thoughts on kind of what our resuscitation goals are other than hemoglobin?
Yeah, it's the INR makes it really difficult. I mean, when we're talking about procedure, mostly this has been studied in kind of all comers for procedures in the sort of peri-procedural period of any type in cirrhosis. Maybe not someone who's undergoing variceal hemorrhage. So kind of take for this what you will, but in terms of assessing it, that INR and using kind of those traditional metrics is not really the best way to assess someone's true sort of bleeding risk and bleeding and their coagulation state. As you guys have probably used plenty of times in the trauma setting, I think that we've moved. There's the last maybe almost 10 years or so. There's kind of a push and a move more towards functional assessments. So thromboelastography, ROTEM, things like that,
Yep.
and using that to guide the resuscitation or the product transfusion efforts. So, if someone may need more platelets and give them that. Now, with the caveat that you're not going to get them super high on that. They have portal hypertension. They're all good. You're basically sequestering the spleen. You might as well just dump the platelets on the floor at some points. And when it comes to things, like other factors, if that's something where it may PCC, whatnot, would be required based on what the TEG results show, then okay, maybe they needed a little of that, but I never set like an INR goal because in the end, you'll be dumping FFP into this person. You're over resuscitating them with product that actually can increase the portal pressure and the portal systemic gradient there, thereby making hemostasis and you're bleeding potentially worse in that standpoint. So in terms of, I mentioned, using those guidelines, you'd think, okay, well, does that really work better? So there's been studies, this was like 2017, 2018, where they had kind of all comers for all procedures. So again, maybe this doesn't apply to our patient right now, but using the TEG and ROTEM derived strategy for product resuscitation was required less products and actually had less, or at least did not have more bleeding events than the INR and platelet, kind of the traditional driven strategy of blood products. So, prior for a patient like this, where time is of the essence in a sense, and I know what we need to do and what I have to do. I would rather him be resuscitated with other things than be concerned about his INR if it's one of those things where we have time per se, or if that may be a limitation to another specialist doing another kind of intervention, then I would kind of be more in favor of getting a TEG or a ROTEM on Mr. Ramirez.
Yeah, definitely on team tag. We
Yeah.
we definitely have used that preferentially at my institution, but I think it's an important point, which is that, not only do you get results faster, you get a more holistic assessment of the
Mhm.
entire coagulation cascade, but there's actually RCT evidence to support using that as a target, as opposed to the sort of traditional INR less than blank, which is
Right.
often a made up number.
Right. Right, and remembering what the purpose of the INR is, what it was developed for, was not for assessing cirrhotic patients.
Right.
It was for assessing the function of a drug, which we really rarely use anymore. To that end, should all these patients be getting 10 of IV vitamin K?
No.
Just a no. Just a no. Yeah. So I mean, I think
If someone was like, I gave vitamin K, I'd be like, "Well, okay.
cool. Yeah, I mean, I think I kind of asked that tongue in cheekily, but it's like again, if recognizing target audience here, and then the release timeline for this
Mhm.
particular show, a lot of folks are going to see that elevated INR who are early in their training, be like, oh well, vitamin K will fix that. We should just give them vitamin K. But I
Yeah.
think, like the reality is that this is not a vitamin K or a vitamin K deficiency driven process. The
No. Yeah.
INR is deranged as a function of this patient's underlying liver disease, which is
Yes.
quite a bit more complex than just like an INR in isolation.
Right. Exactly. Yeah. So yeah, I guess I answered that poorly, but yes, keeping in mind the physiology of it in general is that you are missing the factors to clot entirely. It's not a little vitamin K. It's not like it's like warfarin or something like that.
Right.
So that it's just not around. That's why if you were to give something, if you had extra vitamin K lying around and it was about to expire and you gave it, okay. But if they needed
Right.
something, I'd say please go with PCC generally.
Give
Or
them the
something more concentrated.
factors, not the
Yes.
Substrate
For
cofactor
yeah,
for
I
the
guess
factors to.
cofactor of it. Yeah, right. Yeah,
Yeah.
the factory ain't working.
Right. Just dump more cofactor there.
Yeah.
Okay. So, one thing I wanted to touch on too was I'd mentioned, we had the octreotide going, and you talked about, David, what kind of why that's helpful in this case as opposed to your non-variceal bleeds. I'd also mentioned ceftriaxone, and so we talk about how we didn't really get into this, and in the interest of time, we won't. But those folks with ascites coming to the ER, really, your guidelines indicate tap them. They all get tapped. You have to
Mhm.
roll out SBP. That should happen in the emergency department. Infection risk in cirrhosis is pretty significant. How does that change, or what is the relationship between infection and variceal bleeds?
Mhm.
And what are your thoughts on kind of current practices using things like ceftriaxone as opposed to broader spectrum drugs when we do recognize the increasing incidence of ESBL organisms, etc.?
For sure. For sure. So, just to say this up front for the trainees listening. So right now, the American and European guidelines all recommend antibiotic therapy in patients with variceal hemorrhage. So the AASLD, that's the American Association for the Study of Liver Diseases, recommends 1 gram of ceftriaxone every 24 hours for 5 days, or until stability to discharge, whatever is sooner, in the absence of obviously an active infection. So if you do a tap and you find something, then of course that you would finish out the normal course for that. So the question is, okay, how does this come about? Generally, it's thought that the bacteria are entering the acidic fluid from translocation from the gut, given that they're gram negative and maybe anaerobic, just that kind of enteric sort of milieu that predominates of those kind of organisms itself. So cirrhotics themselves, they are at very high risk for bacteremia, given that a large portion of your body's reticular endothelial system is actually within the liver. So keep in mind that it's not just hepatocytes processing, say, alcohol and other things in the liver too. There's a lot of immune tissue in there as well. So if you knock that out, or you include that in the dysfunction from that disordered healing that I was discussing before, suddenly you don't have that significant ability to filter and remove bacteria from your bloodstream. So I remember, a long time ago, I was looking at this, and there was a pretty elegant sort of study of, they had these mice, just to kind of prove, I guess, the use of the functionality of the liver in this system, is that they radio labeled gram positive and gram negative bacterium, and then inoculated and gave it in the bloodstream of the mice. And then when looking at it, the radio tracer, a significant portion of it was in the liver, actually, in the end.
Hmm,
So I thought that was pretty
Hmm.
cool. So it always
very
sticks in my
cool.
mind of like, yes, infections are what are most deadly for people who have cirrhosis. So anyway, high risk for bacteremia, especially when you're talking about if there's translocation during the bleeding. And then there's thoughts that maybe continued bacterial infection might play a role basically on the way that the bacteremia and the toxins from the bacteria in the blood could act on the endothelium to make rebleeding more likely.
Mm.
Now, there is a bit more controversy than previously thought about primary and secondary antibiotic prophylaxis and cirrhotics kind of at baseline. So there's a lot kind of to be determined about that. At this point, I will say in my clinical practice, and I would, maybe recommend this for the trainees listening, is that just to give the antibiotics, follow kind of the guidelines as they are now, but keep abreast of the issues. And then, finally, you mentioned the choice of antibiotics. So, of course, the ASLD's guidelines mentions that yes, they use ceftriaxone because of the rising quinolone rates. Now, I think originally this was tested with norfloxacin, so obviously a fluoroquinolone for those. And then ceftriaxone was transitioned to ceftriaxone because of the resistance rates. There's a small retrospective study. I believe it may have been single center, but we'll have to check up on that. In which cirrhotics are screened for MDROs actually at the time of their bleeding, but still given the routine antibiotics. And those who screened, with risk or colonization MDROs, despite a given a antibiotic that probably was insufficient to cover with those, no increased risk of rebleedings, infections, or death. So again, that draws into question of whether or not that the coverage is 100% needed for those ESBLs or other MDRO kind of organisms that we're talking about here. So that's kind of where it is right now. I think in my practice, I'll still follow the guidelines as they're written, but more to come. And then when we're talking about secondary antibiotic prophylaxis, maybe someone who's had SBP before. Again, this may not require for Mr. Ramirez, but I believe it was last year in the American Journal of Gastroenterology. It was really good paper from it was retrospective, but from the VA system about those who had SBP, and secondary prophylaxis may actually put them at higher risk for more frequent and more severe infections with those ESBLs. So a lot of controversy about that in the field right now. I would be curious to see how that'll change over time. Now, again, keeping in mind the severity, and I mentioned of the physiology and the patients that we're talking about. You think about doing a trial, a placebo controlled, or whatever on that. Sort of ethically,
it's hard to enroll encephalopathic people with variceal bleeds at the time.
I'd say that they're like of their free will enrolling. Yes, of course. Yeah. So a lot to talk about. So I sent you guys, or included you guys, a link here. It's from the ASLD, so the big kind of Liver Society of America's Liver Fellow Network. So that's a core series of topics or controversies, and it sums up kind of the evidence. Therefore, it's great rounds fodder for the trainees listening here. But this will be in the show notes hopefully, and it's the controversies about antibiotics and SBP prophylaxis. Or the title is "Why or Why Not." So something I highly recommend you to kind of keep this conversation going, or for you guys to get kind of the history and then maybe where the future directions are going of this topic.
Awesome.
Excellent. Yeah. So some nuance, if people want to go to the show notes and read more about this topic, that's great. So just sort of summarize where we are so far. We've got this guy who's got known cirrhosis, who's got a GI bleed that we think is variceal. He's got obvious synthetic dysfunction based on his INR and his low platelets and whatnot. And then, we've talked about kind of initial steps, right? Like we're using TEG to evaluate need for transfusions. We're sort of targeting like a normal, low normalish blood pressure. We're using pressors, using blood. We've talked about the role of octreotide, like you said, as an abdominal pressor. And we talked about the role of ceftriaxone because of the high risk. Let's take it in another direction now and talk about airway. Something we always love to talk about in this show. So what this guy seems kind of tenuous, right? Like I think Cyrus, you used the word gurgling, which always makes me nervous.
Yeah,
we've heard GCS-10. Like David, what are your thoughts on managing the airway of somebody like this?
Oh yeah, I mean, with someone like him, I would strongly recommend intubation. In terms of any guidelines, it's just kind of mentioned very briefly in the ASLD guidelines on variceal hemorrhage, but it's recommended to intubate all patients with high suspicion for variceal hemorrhage, given the high risk of aspiration during the endoscopy. Now, keep in mind that the blood has to go somewhere. It's either up, gurgling out, so he's already had hematemesis, or it's in the stomach sitting there, and it may be both at any given time, obviously. Then let's take in fact that he's already has maybe some grade 2, maybe grade 3 hepatic encephalopathy, so airway protection may be necessary at baseline for him if we're getting into that grade 3 or maybe even further there. But then thinking back to like my procedures as well, you may have seen times where someone does an EGD, maybe not for variceal hemorrhage, but an EGD, and so, well, I don't think they intubated every single patient. That's true, but keep in mind what we're doing here and what we need to get done. So he's gonna, let's say we don't intubate him, he's still gonna need sedation to get through this. He may have retching, vomiting, things like that brings the blood that's in his stomach back up. To be able to see the stomach and the esophagus well, I'm gonna have to insufflate with either room air if that's what your center still has, or we have carbon dioxide. Either way, I'm expanding his stomach there beyond what's already in there. And then, on top of that, I'm lavaging with a lot of water. So we're having all this stuff go in the stomach. The large capacitance of these varices with their blood is just pooling in the stomach. It's high risk for vomiting and potential aspiration up there as well. So, I would say generally in my practice up front, I'm kind of asking for it. I think it's much better to do it a little bit more controlled prior to the endoscopy than, me yanking it out, us having to move the bed, move the stacks and everything and do kind of more an immersion intubation while he's, in the process of aspirating on blood that he's vomiting and other things there as well. In terms of, then it's, you know, when would you consider extubation? Again, I don't, drive that myself, but once, if we have hemostasis, the patient has a lower aspiration risk, then, the ASLD says you can consider extubation kind of as quickly as possible afterwards. But this is someone in whom I would certainly say is an intubation is warranted up front.
Yeah, and I think you hit a lot of really important points, and sometimes I see people are like, "Oh, well, aren't you gonna scope downstairs? Can't anesthesia do it?" No. This is somebody who
Bedside
needs to be
ICU. Oh
intubated
yeah.
in the ICU. I think sometimes you hear, like, reluctance to intubate, like, "Oh, they're hypotensive, it's a high risk." Well, I mean, from my perspective, they're only gonna get more high risk.
Hmm.
The amount of blood in the stomach is increasing, not decreasing typically. And so, better to err probably on the side of intubating this patient a little too early than a little too late.
I agree, Nick. And, when I think about this patient, this is sort of like the final boss of critical care fellowship. This is a dynamic patient who has very high mortality, pretty high
Hmm.
mortality on their best day. They're coming in with a mixed shock state, distributive elements, certainly hemorrhagic elements. They've got altered mental status. They're in need of an airway. They're going to be in need of some vascular procedures. We're going to talk about that in a second. So yeah, I think it's very important, and David did a great job highlighting this. It's very important to be aggressive about taking that airway, managing these folks, creating a safe environment for you, David, and your colleagues to do the work that needs to get done. To me, it kind of goes without saying that these are folks that need to be treated very aggressively with a great deal of respect given the underlying pathology, and not really the time to try and color outside the lines necessarily, but rather just make sure that you've created a safe environment to get the job done.
Yeah, exactly. I think, bias to action is really important here. Cyrus, you and I have talked on prior episodes about the anatomically difficult, the physiologically difficult airway. Well, this is both, right? I mean, this is somebody who's, got high risk for soiled airway because of blood and vomit. This is also somebody who's got high risk of hemodynamic collapse with induction because they're already in a hypovolemic and vasodilatory state. So there's a lot of risk factors. This is going to be a risky intubation, but I think in general, it's better to sort of face that challenge head on, get the product in the room, get the pressors going, get all your team ready and do it in a controlled, planned manner rather than waiting too long. Because I often see cases where people wait too long and they're like, oh, we can send them to this other hospital without intubating them. And there's just a very high risk of bad things happening when you do that. The fact that somebody looks okay right now, that's probably illusory. That's probably a temporary thing, and this can get bad quickly. And
Yep,
so, it's often better bias to action too soon rather than too late. Those are my 2 cents.
absolutely. So Nick, yeah, what I'm hearing is that like in many cases we're sort of on the same page here. I am curious though to hear from you because I don't think David's going to have a huge opinion on this matter. But when you intubate these folks and you're thinking about induction strategies, anything in particular that kind of rises to the top of your list?
I mean, I think there's a lot of don'ts and a few do's. There's a lot of
Totally
don'ts
agree.
like don't use benzos in these patients. Don't use propofol in this
Yeah,
patient.
don't give him a huge slug of propofol.
Yeah, I think, the jury is still somewhat out on the etomidate ketamine debate. I'm a big proponent of ketamine, especially in folks like this, more
Agreed.
hemodynamically neutral. I think that's the way to do it. As far as, your choice of, what neuromuscular blocker. I'm going to use rocuronium. Often these patients have renal dysfunction. Often their K is high. I think basically I do almost all of my intubations with ketamine rock, and I think kind of works well in everybody, but it works especially well in this case because you avoid some of those landmines. I think the other thing too is to be cognizant that they're probably going to lose some of their preload. They're going to get vasodilated when you induce them, so they're going to get more hypotensive. And so really important to have a strategy where you have ideally blood infusing, second best some crystalloid ready, and you should have some push dose pressures as well. And then finally, we didn't say this, but I'm going to say it very explicitly. This is a situation where you want the person's head really, really, really far up. You want them as high up as you can. You want gravity holding all that blood in the stomach, and you want 2 suctions at least.
Yes.
Right.
I was waiting for that, Nick.
Yeah. I mean,
I've seen those cans fill up very quickly. Yeah.
Yeah. And, I'm just thinking of the last time that I did one of these where, you almost have to lead with suction in order to see anything and kind of leave suction in, and then you can use your second suction if you need to. But you need a lot of suction in these folks. And you want gravity working for you.
Excellent points. Yeah, I think a couple other caveats that I would just add is if you have those, not that we are sponsored by them or anything like that, but those Ducantu catheters are really nice. They're kind of larger, stockier, and side note, we're happy to be sponsored by Ducantu.
Yeah, I was hoping for that. Jeez,
I'll say that. But
think like an entrepreneur.
Those are great if you have them in your shop. They do a good job of kind of, again, it's a larger cross-sectional area. More suction can be applied per unit time. So I love those. And then what you said, Nick, about kind of 1 is none, 2 is 1, park 1, have 1 that you can use. And then the other thing I'll just say is and maybe this is a hot take, although I don't think it is for us, I'm still using a video laryngoscope for these cases, but I am not using a hyperangulated or a deep blade. We talked about this before. But the point is, that standard geometry video laryngoscope works just like a regular works just like a regular laryngoscope when you lose video. And if you do a great job with suction, and if you have that kind of window to get the tube in place, you might actually be able to use the video versus your standard Mack or Miller, which obviously there's no video there.
Put your best foot forward. Video gives you a higher chance of first pass success. Totally agree. Listeners should go back and listen to our episodes on the physiologic and anatomically difficult airway. We talk a lot more about this there. We even review the literature of all the different suction catheters and which ones can suck, how much liquid, how fast, or whatever. So yeah, go back and listen. Those are some gems.
Which ones suck the best?
Yes, right. Yeah. Can I make a quick point there? Actually, that was something really quick. You were mentioning about renal dysfunction as well in these patients. So some of the medication you may be renally dosing as part of induction. So if you happen to get labs before, or they got labs in the ER before they came up to your ICU or something like that, or wherever you're practicing, if you have labs before, keep in mind that a lot of these patients will be, they'll have, even if the creatinine is normal, it's their functional renal dysfunction because of the physiologic abnormalities. I already mentioned the renal artery vasoconstriction, but then also keep in mind that if someone has a very high MELD and has had cirrhosis for quite a long time, that they'll have sarcopenia as well. So even a normal creatinine may still be someone who has functional renal dysfunction as well.
Great point.
A creatinine of 1 may be a double of their baseline.
Oh yeah, it may be they should, normally if they had normal renal function, they'd be at 0.4. But if 1,
right,
then that's much higher than where they should be at. Question for you guys though. So I used to see a lot of people, with these preferentially using ketamine, at least in institutions where I've been most recently, it's not used as much for induction. Is there a reason for that, or is there something that you guys consider about this? You mentioned sort of a debate between.
I think Elon Musk has been using it. There's been a shortage or something.
Okay, good.
Yeah. I think, I mean, Nick, I'm curious, so again, like I said before, like many things, we have a kind of a similar mindset on a lot of critical care management. So I think there's enough of a question when it comes to etomidate with respect to this adrenal insufficiency that can rise at some point after dosing these patients. So you can kind of have this lingering shock state and you're not entirely sure what you're dealing with. Come to find out it's related to this temporary but real adrenal insufficiency that you can see with etomidate. And we've seen a number of studies now that do support that notion, or a number of studies that do support that phenomenon, I should
Mm.
say. And then on the flip side, with ketamine, as a kind of reminder to our listeners, you get pretty good analgosedation when it's dosed appropriately. You get release of endogenous catecholamine, so essentially endogenous vasopressors.
Hmm.
And to the extent that it's helpful, you get some bronchodilation. You also get bronchorrhea, which can be problematic when you're already dealing with a contaminated airway.
Oh,
Um,
interesting.
but but when I balance those two options, that's kind of why I tend to lead towards ketamine myself.
Hmm.
Nick, what are your thoughts?
Yeah, I think the criticism of ketamine that I hear most commonly is because it's controlled, it's not in the intubation kit, so it's another step to get it.
Well, that's a
So
very
that's
good
that's
point,
kind of a
practically
logistical
speaking.
issue. Another concern that people raise sometimes is that the half-life of ketamine is often shorter than the half-life of the rocuronium. So, the concern would be that somebody will experience awareness under paralysis, which is a horrible feeling.
Yes, yeah.
But that's not an argument to use a longer acting induction med or to use a shorter acting neuromuscular blocker. That's just an argument to start sedation after you intubate somebody.
Yep.
Right. So I think, that people sometimes they don't feel comfortable that they're going to be able to get that med as quickly. So they prefer etomidate. Sometimes people feel like they're not going to get additional sedation quickly. So that, and those are reasonable concerns. I just think there's a better solution, which is just have some low dose sedation ready to go. Okay, before we move on, we are proud to announce that this episode of Critical Care Time is sponsored by the Difficult Airway course.
The Difficult Airway course, Critical Care, is the premier airway management course designed specifically for critical care physicians and APPs by practicing airway experts who understand the unique challenges of managing airways in the ICU.
This includes deep dives into topics including anatomically and physiologically difficult airways, rapid sequence intubation, awake intubation, surgical airway techniques, airway ultrasound, high-risk extubations, and more.
Now, you won't just be watching folks manage airways. This course provides hands-on, evidence-based, immersive training with code airway stations designed to prepare you for a wide range of situations you're likely to encounter.
Plus, the Difficult Airway course is taught by world-renowned airway experts who share the tips and tricks they've picked up over many years on the front lines.
Now, you may be wondering when you could participate in such a course.
I was just wondering when I can participate in such a course.
Well, Nick, as luck would have it, there's a course being held at the Manchester Grand Hyatt in sunny San Diego, California from November 14th to the 16th.
Get excited.
And when you register, your tuition not only includes entry to the course, but a copy of the new textbook, Manual of Airway Management in Critical Care.
Plus, since, if you're hearing our voices, you must be a Critical Care Time listener, you are entitled to a special discount. Use discount code CCTime25 at checkout and save $250.
You can find all the details you need at www.theairwaysite.com/critical-care.
Gain the confidence and competence to manage the most complex airway cases, even when the pressure is on. Because when it comes to airway management, there is no such thing as being over-prepared.
And now, let's get back to the show.
So now that we've talked about airway, let's talk about vascular access a little bit. So I think going back to the question stem, this patient's got two 18-gauge peripherals. How much should we be like, oh my God, we got to get a triple lumen. Like this person needs better access. How important are those things, and how much should we be worried about correcting quote unquote coagulopathy before doing procedures?
Yeah, I guess the access thing, in terms of the GI side, I'm not aware of necessarily any literature on that. I think it's just whatever you and your team or whomever is taking care of the patient on their way to the ICU or anything decides, as long as it's appropriate access. Obviously, maybe like a 24 gauge in the hand wouldn't be the greatest of options for us, but I would generally leave it up to the ICU team. And that's where, oftentimes when I mention about like a very scary scenario where it's kind of like you really want to get in there and do something that really affects even the GI team as well. I want to get in there and I want to scope, but I know that if we already mentioned intubation, but if they don't have appropriate vascular access, something like that, we may run into a period in which the patient may do worse, even though we're all trying to do the right thing. So that's where a lot of times with my team, I'll say we need to kind of step out, let them, get any kind of lines that you guys need in them for monitoring and or for resuscitation. And then once those are done and we have kind of things running in that, then we'll say, okay, we can proceed now with setting up our scope and everything like that. In terms of, like, you mentioned transfusion strategies, that's kind of an interesting thought. Now, again, the 7 gram trigger still kind of remains, unless some systemic disease requires it, so ischemic coronary disease or something of that nature. So 7 is still what we stick with. Now, in terms of, we already mentioned more following elastic testing in terms of pre-procedural. Now, if for these folks, we're kind of an emergency situation. I'm not pushing for a goal INR or a goal, you know, any of the metrics on any vasoelastic testing or anything like that. But it is recommended against sort of this more liberal usage of FFP. If I said so, Mr. Ramirez is at 2.1 INR. Let's get him down to less than 1.6 or less than 1.5 or whatever ridiculous things that you guys have seen, or maybe what some of the trainees listening have seen at whatever institutions they're at. The liberal usage of FFP and other blood products can lead to worsening survival and worsening portal hypertension because, again, there is this venous group or the portal system that is now decompressing because of the variceal hemorrhage. It has a certain capacitance and it'll be continued decompressing actually. And now you're just filling it up with more and more and more and more from the colloid that you're giving them. So trying to stay away from over resuscitation is actually very important in the cirrhotic population.
I think that's a great point. Yeah, I think just to comment on the vascular access side, I think we probably should do a whole episode on this topic, but
Yeah.
I think people often forget that 2 18 gauges can get as much flow as 1 triple lumen. Right? A triple lumen is not better. It's just it's reliable. It's not going to fall out. It's not going to blow as easily. If you need access, you should be thinking about like either a RIC or like an introducer, like something big that you can pour blood into. These
Yep.
are the patients. Usually my approach is intubate, central line, art line. Maybe if they're really tenuous hemodynamically, I'll do the art line first and then intubate and then the central line. But in general, these patients need these lines. They're sick. You need to resuscitate them. You're going to be drawing blood frequently. You might as well get the art line for that. I think sometimes people fixate on the central line. Like, I can't resuscitate without the central line. And they just forget that, like, I'll take 4 peripherals, over 1 central line. And I can have 4 nurses place 4 peripherals much faster than I can even get like my gown and gloves on, So just don't forget the basics. And often the basics are better,
Yeah. Yeah, and I think the only other things I'd add or kind of elaborate on are, if someone's like peri-arrest and they don't have access, you do have the IO. Remember, you have
Yeah,
the
good point.
IO. No one loves to put those in a patient that's not kind of like actively being coded, but if it's what you got, it's what you got, and it can be used for transfusion of blood products, especially if you put some pressure behind it while you're establishing something else. What can that something else be? Nick, you're totally on it. Good peripheral access is perfectly reasonable. Alternatively, like I have become a big fan of the the Mac catheter or the Mac introducer
Mm,
because it gives
yeah.
you a resuscitation line, it gives you a med line, and then that introducer itself allows you to float a swan if you have to, if it's really like an undifferentiated shock or mixed shock picture. Or you can just kind of shove a triple lumen down there, and now you have 4 med lines and you have a resuscitation line as well. And they're pretty easy to place because the dilator lives inside the introducer, so it's similar
Just
to
like a
putting in like
Cordis.
a
Yeah.
cordis exactly. But yeah, otherwise, I think from a access standpoint, those are kind of the pearls that I bring to the table. And I think from a transfusion standpoint, David, yeah, your points are well taken. Being overly aggressive with your FFP is probably the wrong answer, and in fact, there's evidence to suggest it is in fact the wrong answer.
Mhm.
Um, Transfusion thresholds probably don't need to change a whole lot, but just again, I would also throw back to the previous point of like a hemoglobin of 8.8 and someone who's actively dumping blood is not helpful to me. I'm
Yes.
going to
Yeah.
treat what I see. I'm going to, activate my massive transfusion protocol, use the rapid infuser device, so on and so forth, to make sure that that patient doesn't arrest.
Yeah, and I think an important caveat, people often remember that Villanueva NEJM paper where they found that transfusion to a hemoglobin of 7 in the setting of GI bleed was sufficient, but important to read the exclusion criteria that patients who were hemodynamically unstable were just given transfusions.
Yep.
So it's really we're transfusing to hemodynamic stability or a hemoglobin of 7. If they're
Yep.
unstable, I don't really care what their hemoglobin is. I'm going to give them blood.
Right. Exactly. I think, yeah, we touched on that last episode too, that like reading the fine print of something like that, because then you'll see 77777. And I've certainly had times of, someone who is still hemodynamically unstable, but on a, you know, iStat or something like that. I don't know if that's a proprietary brand, but anyway, some kind of uh
Another potential sponsor for the show.
yes, right, yeah. It says, oh yes, the hemoglobin was 7, so we're going to stop. And it's sort of like, oh yeah. But it's funny, I think, I'm thinking back to most recently, a couple weeks ago, when my fellow and I had to put a Blakemore in somebody. And that was a really well run resuscitative effort, and it was, you know, them taking the Airway. There's someone putting in a central line. I think because it kind of it evolved so quickly that while the nursing staff in the ICU did a great job placing very large bore peripheral ones as well. There was someone placing an art line, and I think he had also an IO in there as well. So he had kind of all things come in when he came into the ICU there. So it was really fantastically run, and that's kind of what you need as a full team effort there as well.
Yeah,
Not
I
that I have
mean
any opinion
that's
about any of that kind of thing, but at least it's an example, for the interns and residents listening, and maybe medical students or whatever. Just remember that it's a team sport, just like everything in medicine, and like just find a way to help where you can with your
right.
level of expertise and training, and like that's how we have the most success with these kind of patients.
So true.
Good point.
This is communication is critically important here, and this is another one of those situations that, in my mind, is really no different than a cardiac arrest than a code.
Right.
You have
Yeah.
your pieces in play. You have to make sure roles are appropriately assigned. Good closed loop communication. And as that kind of vignette that you just shared with us demonstrates, when you do that and everyone's kind of like focused on their task, and you have someone sort of overseeing that and doing the air traffic control bit, that's how you save lives. So yeah, I'm really glad. Thank you, David, for sharing that with
Yeah.
us.
All right. Well, I thought this was going to be kind of a softball question, but maybe the answer is more nuanced. So I was going to ask you, what is the role, if any, for TXA in these folks?
Yeah. So, when full disclosure to the audience that we don't do this live, I can't come up with all the stuff off the top of my head. When I saw this in the script, I was like, oh my God, these critical care guys, here we go again about the TXA.
Yep. Love it.
So I was like,
These
all
guys are
right.
obsessed
Let
with
me just do a
ketamine
quick
and TXA.
Let me give them the benefit of the doubt, and I'll do a quick TXA, transexamic acid, in variceal bleed search in PubMed. And I was like, I can't wait for this. Turn up nothing and say there's no role. Now, for those who listened last week or whatever, whenever my last episode was published, we had a really good discussion about TXA and kind of all comers of the non-variceal GI bleeds, and that now the evidence is kind of meh on it. We mentioned kind of the halted trial there, but we kind of posited that maybe it was because of timing of administration of the TXA or something of that nature as well. Sort of difficulty to know truly when someone may have started bleeding, particularly in some maybe less severe upper or lower GI bleeds there. So got on PubMed, said, okay, let me take a look and see what I can see. So there was a study, actually, an RCT that was published in Hepatology, so the Journal of the ASLD, last year, that kind of answers that question. So this was in patients with child Pew B or C cirrhosis, and it was all comers with GI bleeding in 24 hours. So anybody who had any reason to have an upper GI bleed. That being said, amongst both groups, they had a TXA and a placebo group. 85% of the patients were bleeding from esophageal varices, gastroesophageal varices. So we'll talk about kind of where those delineations lie, and or isolated gastric varices. And 70% of the patients underwent esophageal variceal ligation or band ligation. So that's for those who may have seen this in their time in their residency or other training, it's where we put the rubber band around the bleeding varix as a primary intervention. So I would assume that at least that was the source of, or at least the primary source of bleeding in at least 70% of these patients. So this may actually really apply to Mr. Ramirez. So the primary endpoint of it was the proportion of patients with failure to control bleeding at day 5. So if you had, the hemostasis didn't work at day 5, that was what they were assessing there. And of course, secondary endpoints were from day 5 to week 6. So we're going all the way out now, like 42 days out, or death, because everything. That's the secondary endpoint. So there was a significantly lower proportion of failure in the TXA group in the primary endpoint. I believe it continued for the secondary endpoints as well. So
right, and the criticism of this study is that there was less bleeding with TXA, but mortality was numerically but not significantly lower with TXA.
Yeah, exactly. So there is some improved success of EVL in compared to the placebo group in patients undergoing their kind of first time EVL as well. So for Mr. Ramirez, since we don't really know his history, this may be his first time getting a variceal hemorrhage, maybe his first time getting banding, it may be beneficial. And this was enough where, in future practice, depending on if the patient sort of fit the mold of this, I may actually consider it in some patients going forward. Of course, and now this time I'll stop poo-pooing TXA and this the population of GI bleeders, and maybe consider using it more, recommending it more upfront. So, it really shut me up. I think we can put the PubMed.
Yeah, I'm just looking at your comments in the outline here. David, 7:54 a.m. yesterday. You all love TXA.
Yes.
Yeah.
But yeah. So anyway, interesting that there's some nuance to it, right? I mean,
definitely.
The source for that that theory about the time to bleeding is basically, what's that meme where it's like, I made it up? That's basically the source. Like, we don't know for sure that's why, but I think it's plausible.
Yes,
and
it is.
This is a really interesting study. So I'm curious to see where this goes. I'd love to see this replicated, because I mean, it would be interesting if TXA had no role in GI bleed unless it was a variceal bleed and you knew it was like, okay, just started.
Yeah, and that's where maybe, when we're getting, the call of the GI bleed patient and cirrhosis, but that's where, forming our differential as we're looking at the history, or getting, the call of asking, have they had varices before, other signs of clinically significant portal hypertension, maybe even if we don't know, that's okay. What are their platelets? If they're, below 150, then I can say, okay, there's a high likelihood they have clinically significant portal hypertension. And then if it seems like that may be from a variceal hemorrhage at this point, like I said, I may actually, if I follow this kind of line of evidence more and see if more studies can replicate this, maybe I'll consider TXA in these people going forward. So shut me up.
So another, to kind of close out this discussion of medications, we talked about octreotide and the utility there. I think that makes pretty good sense. 2 agents, so one, of course, related terlipressin, and then also your pantoprazole. So is there a role for terlipressin in these folks? If so, does it differ at all from octreotide, assuming it's available to you? And then PPI, is that something we're using in these guys?
So, regards to terlipressin versus octreotide, I can't find any evidence that there's any difference for variceal hemorrhage in terms of outcomes. Now, keep in mind this does not apply. It's completely different when we're talking about like terlipressin, HRS-AKI, and I'm not really assessing that, but if we're taking just the state of Mr. Ramirez as he is right now, that if octreotide is the one that you have, then I would recommend using that. In terms of PPI, again, when you first get this person into your ICU or your emergency room or anything like that, it's an undifferentiated GI bleed. You're not wrong for starting PPIs as well. Cirrhotics can get ulcers too. So it could be of some benefit, and it's of little risk. If it turns out to be portal hypertensive bleeding, and once you've confirmed that with endoscopy, then certainly you can just stop the PPIs.
Isn't there some thinking too that like the low pH makes the clotting cascade less effective or something? Or is that just something I've just fabricated?
Oh, in terms of why we start PPIs on kind of all comers? Yeah, so that's kind of what I've always been, the dogma is that, eliminating the acid, it helps, I guess, just improve the clotting cascade and the, coagulation of the blood. So that's at least what I've always heard.
Arm wavy cytokines. Okay.
Yes, like, oh yeah, things,
yeah.
Yeah,
there's the hand wavy emoji.
Yes, right.
But I think you're right though. I think my recollection is that acidosis can impair kind of the clotting cascade. So that sounds about right. Maybe we'll have to get Matt Rendo back.
We know that acidosis impairs clotting systemically, right? Like if somebody's pH is 6.9, they're not clotting well. So it seems reasonable that if their stomach has a pH of like 4, it's probably not clotting really well.
Yeah, probably.
But maybe the danger of extrapolating from one place to kind of a very different place.
Good.
Anyway, so we've now intubated, we've gotten vascular access, we've given the appropriate meds, we've started resuscitation. What now?
Yeah, clock's ticking, and we're getting ready to hopefully have you guys come in and do your thing. Anything in terms of timing or anything kind of specific before the scope begins that we need to cover that we haven't already discussed?
Not necessarily. Now, we talked about the significant risk, the mortality risk being very high in people with variceal hemorrhage. And so that's where the timing does change a little bit based on, the guidelines. So keep in mind, remember the last time we talked, I said, you know, generally with resuscitated efforts, and we kind of say urgent sort of within 24 hours or so. You may go sooner than 24 hours if it's the right time to go, and that's okay. But with these, we truncate that by, the half. So it's 12 hours is generally when we want to have the time to first endoscopy. So that's where generally, it becomes a little bit more time of the essence and more urgent in terms of getting these people to a scope or other kind of definitive therapy if that's required.
Got it. Got it. Okay, cool.
All right, so let's think now about kind of the role for the Blakemore or Minnesota tube.
Mhm.
Either as a bridge to that endoscopy or after like failed endoscopy.
Yeah.
So what want to could give our audience just like a what is a Blakemore or Minnesota tube?
Yeah. So, how to describe it non-visually? So it's
It
basically,
looks kind of like a red like a hot dog
yeah,
with
basically,
some
yeah, like a
balloons
red
on it.
hot dog, and it's got two balloons on it. So there's the more round one on the end. That's the intragastric balloon. There's the longer one that looks like the inside of an esophagus, and that's the esophageal balloon, obviously. So when you pass it, you're trying to confirm placement by placing the intragastric balloon with a very small amount of air in it. So I'm talking like 50 cc's. Have them, if you have a chest X-ray machine that's come for the intubation, keep them around because you want to confirm placement there. And then basically, what everyone sees and remembers is when the intragastric balloon is fully inflated. You need to have that traction because where the veins for that supply the varices come from is actually more distally in the GI tract, so they come up from the fundus and cardia of the stomach through more proximally or up. Use simple directions up through the esophagus as well. So you want to get them downstream. That's why you blow up the intragastric balloon first. But you need that tension on the fundus. So if the fundus is here, you need it sitting up right inside there, and that's where you'll see someone will tie a string or something to the end of the Blakemore tube, and they'll either with a 1 liter bag of saline or about a 1 kilogram weight actually hang that over an IV pole, or in some places maybe people have seen that like tied to a football helmet or something like that, maybe back in the
Yeah.
day. So
Yep.
that's generally how it works. Now that can be used prior to endoscopy, sort of, when I placed mine most recently, it was in kind of a crash situation. The code has, or it wasn't really code, but again, the resuscitative efforts were still ongoing, but it was a way to limit further blood loss in the setting of someone who had a variceal hemorrhage themselves. So quite a scary kind of thing when it happens. I would recommend, and this will be in the show notes as well as a YouTube video of how to place it, because it's not just the tube itself. The tube comes without really a kit with it, so it's about what we did actually to really improve the success, and it made this much easier when I placed it recently as my GI unit. One of the fellows and an attending a couple of years ago made a kit of basically a how-to, and it had instructional guidelines and everything like that, and it made it super easy to play. So I would recommend for ICUs, or if there's anyone who's interested in their GI units, if someone happens to be listening from gastroenterology, to consider making a kit like this, because when time is of the essence, you don't want to be hunting around little stopcocks and things to make sure that you have your tube all set up and ready to go.
Yeah, great point. This is the classic like high acuity, low occurrence procedure.
I
You
knew
do a
you were going to
couple of
say
these a
that. I
year.
was thinking
Yeah.
about that.
And so, I mean, what can you do to set yourself up for success? YouTube video. I have a one pager on this too. Practice simulation. Another couple pearls on this are, it's very, very hard to place it if the person's not paralyzed. So do this after the rock or redose the rock if you need to. It can be very hard to place this if you've tried and failed. So sometimes the plastic kind of just gets softer and it just doesn't want to go
Yeah.
where you want it to go. And so often it's good to have two kits. That way, if you fail with one, you can try another fresh one. I find they often like get kind of old, and like sometimes the balloon doesn't inflate properly or whatever when
Right.
you're
It
testing
loses
it.
kind of pliability. And actually, I'll say a pearl about the difficulty in placing when the plastic gets soft is, if this is coming from a GI unit or whatever. So I used basically whatever biopsy forceps would fit down your gastroscope. You can put that actually in the lumen of the tube, and that helps kind of rigidize it a little bit. So it's easy. It can be easier to pass. Now, as that may be a two-person job, because as you're passing it, you may need someone to take the biopsy forceps out to be able to,
Or another approach that I like is to use a laryngoscope to sort of get into the epiglottis and lift.
Yeah.
Which is sort of the same idea, sort of just like do it. Again, though, unless you have 3 arms, it's probably
Right.
now a 2-person procedure,
For
because
sure.
one person's lifting really hard and the other person is passing it.
Yeah, for sure.
So I don't want to, how shall I say, shortchange you, David, but I also want to recognize the focus of this episode. Can we talk a little bit about the endoscopic strategies and sort of like the tools at your disposal, just so for those of us that are not gastroenterologists, we can speak the language and understand, kind of what's going on to our patient when you're doing your job.
Yeah, for sure, for sure. So, let's talk about just like esophageal varices. We'll keep it simple for now, and then we'll add sort of the gastric varices and everything right now. So, our usual toolkit, you always hear about banding. I've mentioned esophageal variceal ligation or band ligation at this point. So, what that is basically on the end of our endoscope, we have a cap, and through it pass two strings, and on each sort of knot of the strings, there's a rubber band around there. So when you get to wherever the varix is, you suction, you pull the varix within the cap, and then as you turn a dial, it pulls on those strings and sends the rubber band over the cap around the varix, and that's what leads to the hemostasis. Now, obviously, there's plenty of reasons for banding to fail. So if it's a place where they've been banded a lot before, there's a scar that's formed. This doesn't necessarily get rid of the vein per se. It creates an ulcer which scars over, which then is less likely to bleed over time from the previous varix. So if Mr. Ramirez has had banding before, that's something I would kind of want to know to say, okay, are there going to be areas where there's maybe more fibrosis or maybe more difficult? That's band ligation as well. We already talked about the Blakemores kind of are, okay, things have gone really, really bad, or maybe we're early in the resuscitative efforts and we can't do the endoscopy just right yet, but here, let's have something to kind of stop it very quickly. Other things that you can consider again as well, or reasons that it can fail, of course, is that, as I mentioned, the portal system may be decompressed, so the varices have kind of shrunk or decompressed over time. So you may not find like those big varices that are necessarily amenable to banding, or they're not the ones that are having blood come from them or have the white nipple sign of the platelet plug or anything like that. So with the resuscitation, certainly they may plump up again and they'd be more amenable to banding as well. So other endoscopic options. So it has been studied to use hemostatic powders. So TC325, some people may know that as hemo spray is the trade name for it.
I was going to say Imperial Probe Droid. Okay.
That's right. Yeah. Used and studied. It's not an FDA approved indication for hemostatic powders, but it can certainly be used as a rescue therapy if, again, there no varices that you can see or that they're decompressed or something like that, to then resuscitate and kind of live to fight another day, as it were. And some of the more recent things you'll see this, I mentioned last time of Dr. Andy Tao from Austin Gastroenterology and his Twitter, X, whatever you want to call it, feed. Dr. Blood and Guts, he's mentioned about using fully covered self-expanding metal stents. And they are becoming a little bit more utilized, but it really depends on the equipment availability, the endoscopist experience, things like that. So it's not a common thing that you'll see used in variceal bleeding, at least at this point right now. Maybe in the future that certainly will change.
So obviously we hope for the best, right? We hope that the endoscopic procedure causes the bleeding to fully stop. But what happens if that's unsuccessful? Like if the person continues to bleed after you try your best, you deploy lots of rubber bands, and then they're still bleeding afterwards.
For sure, yeah. So that's where we're talking, getting our IR colleagues involved in there. So this is where there's a bit of nuance in there. You're getting a tips regardless, but if there's rebleeding during the admission after maybe I had a successful band ligation, that's where we call it a rescue tips. Or if there's such severe profuse bleeding that I can't do the band ligation or persistent bleeding going on despite my band ligation, that's when we're calling it a salvage tips.
Gotcha. So rescue versus salvage
Yep. Yeah,
important.
that's when you generally
Differentiate.
happen. Yeah.
David, just on that topic of, tips, we sort of discussing that a few times now. Are there specific scores that might suggest getting IR on the horn sooner rather than later? Are there certain features of the patient presentation where, we might be thinking early tips versus salvage tips? Walk me through that if you could.
Yeah, I'd say, with depending on the severity of their cirrhosis and maybe what their meld is and other things like that, and really, as we mentioned, kind of the technical success of the endoscopy is where I would either get IR involved for, let's say, the next day for Mr. Ramirez, or calling them at night if we're considering something like a salvage or uh, a immediate rescue or something like that
Gotcha.
as well. So hopefully we're shooting for, they mentioned that if he's had any measurements of gradients, that we're shooting for a 12 millimeter mercury reduction as part of systemic gradient, and then or a relative reduction by about like 50 or 60% to significantly reduce his rebleeding risk.
Gotcha. And I think you mentioned also in pre-recording this idea of like their meld versus their meld sodium. How does that play a role?
So it's that the meld is a better indicator of 90-day mortality after tips than meld NA or
I see.
Child scoring or anything like that.
Okay, cool. So that's
It was more about discussing about like cutoffs per se. So we want to make sure that yes, there is there's been described cutoffs in terms of mortality and things of that nature, but this is sort of a different beast entirely. If they're actively bleeding and need a salvage tips, and you kind of deal with it from there.
Got it. All right, I want to just turn our attention a little bit more distal, if you will. I just talk about gastric varices as opposed to esophageal varices. How does that change your approach, kind of therapeutically? What tools you use, etc.
Yeah, this would be a really good time to discuss. I mentioned gastroesophageal varices and versus esophageal versus just isolated gastric varices. We'll talk about the Serine classification. So I'm really glad you kind of made the gastric fundal distinction there. So everything has O in it because esophagus begins with an O, where this was made. So GOV1 or esophageal varices extend on the lesser curvature of the stomach into the cardia. These are actually treated very similar to esophageal varices. GOV2 are esophageal varices that extend into the fundus of the stomach. So kind of going up kind of along the, eventually to the greater curvature. And these are not treated like isolated esophageal varices. So that's why every time we're doing the endoscopy, I want to be able to visualize the fundus in someone with suspected variceal hemorrhage to be able to say, okay, is there a gastric component as well? There's isolated gastric varices. So imagine a GOV2 without the esophageal component. So those are in the fundus, and then isolated IGV2 or isolated gastric varices, generally along the distal stomach and the greater curvature, so like the body or the antrum. Although I've seen those more commonly less secondary to portal hypertension rather than splenic vein thrombosis or something of that nature.
I think you lost me at esophagus starts with an O.
Right.
That like British spelling, but go on.
Yes. Yeah, it's very strange when the first time I learned. I was like, what is G-O-V? I was like, oh yes, O esophagus. So
like
British
oedema.
Yes, oedema or diarrhea or whatever. So then the coils and glues can generally be used when the varix is not like actively bleeding, or at least coil especially. It may require endoscopic ultrasonography, which ERS requires further training. So it depends on the GI on call there. So then we're talking about other tips and other variceal retrograde obliterations. So tips and variceal obliteration can be used if there's no expertise in injection, or if hemostasis is not obtained with glue, and then in the emergency setting. And then tips plus or minus variceal obliteration can be used for secondary prophylaxis or rebleeding after the endoscopic therapy.
And when you're saying obliteration, you're referring to balloon occluded retrograde transvenous obliteration, BRTO.
Yeah.
That's the abbreviation. Okay.
Yes. Yeah.
Awesome.
Got it. So what I'm hearing is that it's really important to visualize both, because the complexity is much higher if it does involve either isolated gastric or including gastric
Right. Yeah.
varices.
So that's where maybe it may require my intervention, but getting on the horn with IR may uh, be necessitated afterwards.
Got it.
So that was, I think, an incredible discussion, incredible run through of kind of the soup to nuts, what is cirrhosis, talking about portal hypertension, and then really kind of honing down on the nitty gritty as it relates to varices, both kind of dovetailing your expertise, David, with ours kind of from the GI perspective versus the critical care perspective. As we round out our discussion, sort of finish things off here, I did want to just take a few moments to maybe do almost like a rapid fire, like, okay, the dust is settled, the patient's
Yeah.
doing a little better now. So, so kind of kicking that off, let's say we've achieved chemostasis and things are looking a bit brighter for this patient, for Manny. Um, how do we go about tapering his, like, let's say his octreotide or his terlipressin?
Yeah, for sure. So, I mean, at this point, if it's any kind of portal hypertensive bleeding, I'm still following the guidelines of at least 2 to 5 days of therapy, even after hemostasis is obtained. So, I say keep in mind as we were describing Mr. Ramirez that he's been through a very significant bleeding event. Quite a lot has gone on with him with enough of the significant portal hypertension. We've overwhelmed the thin wall of the varix, and he's had a massive bleed. So that's where I'll tend to, keep them on it even after, for a while, even after hemostasis is attained. So very different than when I'm doing my banding on outpatients. Those folks obviously don't get octreotide when they're undergoing the scope or anything like that because we're doing it more as a prophylactic measure for them. And similarly, if Mr. Ramirez gets out of the ICU and we're bringing him back in a few weeks, 2 to 4 weeks for repeat EGD for banding, then obviously he's not getting octreotide then. But I would still continue it in this sort of immediate state for at least the 2 to 5 days.
Got it. Another question that comes up is potential role for beta blockers in these folks.
Yeah, so I guess if they've never bled before, so maybe this never happened to Mr. Ramirez and he was seen in a clinic or something, you can certainly start non-selective beta blockers. So carvedilol is one that's kind of come more in vogue in both primary and secondary prophylaxis. Or you can do routine screening and band ligation if they have a contraindication or are otherwise intolerant to beta blockers. If they have bled, once you can discontinue the other vasoactive therapies, so discontinuing the octreotide or terlipressin or whatever at 2 to 5 days after the therapy or after hemostasis, then you can consider starting a non-selective beta blocker at that point.
And what does that surveillance look like that you'd mentioned?
Yeah, sure. So let's say we get through a successful EGD and he's discharged. 2 to 4 weeks after that, we are continuing to do surveillance, endoscopic surveillance until total eradication. After eradication, the guidelines say so we'll start the first, do the first one 6 months later, and then it's every 12 months because he's obviously at this point a decompensated cirrhotic. So we're screening him every 12 months for.
And the idea here is that he is at risk for developing new varices.
Yes, yeah, new
of his
varices or anything like that. Yep.
Got it. And that's why you want to hear when the last endoscopy was, because
Right.
presumably
Yeah.
if it was a
What
week
they found,
ago,
what they saw, if there's anything going on from there. Yeah.
got it. All right. And then let's assume we're at like a tertiary quaternary center. Kind of at what milestones do you use to sort of think about transplant? When does that sort of enter the discussion?
Yeah.
Great question.
So the test answer in terms of referral at least is 15. That's quite a low meld. I mean, I don't think there's any region in the country where that could get transplanted without like significant exception points there. But I think it's a good cutoff to consider, saying that if someone is like getting up into the high teens or the 20s, that if you're not a transplant center, you may want to get them referred just to get them to that kind of higher level multidisciplinary care. And of course, there's anything else that requires more IR intervention or surgical intervention or oncologic intervention. So I'm talking like concurrent HCC or hepatocellular carcinoma. Then I would refer them at lower MELs just to get them kind of seen and plugged in with a transplant system sooner rather than later.
Got it.
Yeah.
And I think that's a really good point too, which is that sometimes, smaller hospitals aren't comfortable managing these patients initially, but even in the patients where they are comfortable and they do manage them successfully and they resuscitate them, they stop the bleeding, there's still a role for transfer. Because often if somebody is sick enough to have had a variceal bleed, they're sick enough for consideration of these other therapies at least.
Yeah, you may not get an if there's a meld of 15, like I said, the cutoff, you may not get an inpatient transfer per se, but if someone who may be on the outpatient side would be seen in their clinic or something like that and plugged in for following them along. And keep in mind, we mentioned with Mr. Ramirez that there's a lot that can be done before a transplant to improve his liver health. So we mentioned that his cirrhosis is from alcohol. So getting him plugged in with a clinic that's comfortable in treating him for alcohol use disorder and alcohol associated liver diseases as well would be really beneficial in at least extending time to transplant for him. So that's something to reconsider. And I know we always forget that when we think about the inpatient setting, especially in patients who may have alcohol-related liver disease. But keep in mind, there's still interventions we can make, and that there's a lot that we can do for these folks besides just waiting for transplant.
And maybe another point that we should mention too is that not all of this is alcohol related, right? That there are other etiologies as well.
Oh, certainly, yes, yeah. You could have concurrent, steatotic liver disease as well. So we'd have kind of more of a ALD kind of picture. And we don't need to get into all the nomenclatures of that and stuff, but there's certainly many things that can be going on at once with Mr. Ramirez.
Today, we, I think, did really the Lord's work. Really, David, you did the Lord's work by covering a lot of content in just about an hour and a half, really all related to cirrhosis with a focus on variceal bleeds. We talked about physiology, pathophysiology. We talked about some of the medications we used. We talked airway. We talked access, whole approach to resuscitation. And then we kind of closed things out by really focusing on some of the endoscopic interventions that you might use in concert with your critical care colleagues. So thank you, David, for working with us on this. To our audience, we sincerely hope you all have enjoyed this discussion. And as always, we would refer you to the website, www.criticalcaretime.com, to view our show notes, infographics, etc. Make sure that while you're there, you subscribe to the mailing list and leave us a comment.
Yeah. And now we're at the part of the show where we like to say thanks. First off, thanks so much, David. Thanks for
having me on, guys. This is great.
I would say we should send you some more swag. We could send you a pint glass, but that feels inappropriate. So we'll find some other thank you gift for you.
Perfect. Yes.
Also, big thanks to all of our listeners who have left us reviews, comments, five-star reviews, especially people who have shouted us out on social media, written us emails. We really appreciate it. You guys, inspire us, motivate us, give us ideas for episodes, tell us when we're wrong. We appreciate all of those things. Yeah, if you haven't yet done so, please subscribe to the show, give us a like, give us a 5-star review if you can. Send the show to somebody else. Like if you've got a friend or a colleague and you're like, hey, check this out, just send it to them, right? We want to grow the audience. This helps us.
That's right. And if you want to reach out to us, please tweet or X or whatever it is at us. So at Critical Care Time or individually at Nick M. Mark, at Askins_Razor. We're on Blue Sky, we're on Instagram, Threads, so on and so forth. Some permutation of Critical Care Time, Crit Care Time, whatever it is, you'll find us.
Yeah, and before we go, we'd like to say a big thanks to the team that makes the show possible. So the production folks over at Podpaste for editing, Kurt Belknap for our music, and everybody who contributes to the show behind the scenes. We appreciate all of you.
And finally, our disclaimers. The views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally,
so it was not really Manny Rivers of the Red Sox, right?
Sorry,
this was a
Manny
hypothetical
Ramirez.
patient.
Freudian slip.
Oh, yeah.
This podcast is for educational and entertainment purposes only. It should not be used in lieu of seeking medical advice. With that, thanks again for listening. I'm once again Dr. Cyrus Askin.
And I'm Dr. Nick Mark. See y'all next time.